All right, team, let's get right to it. Welcome to today's mission. Think of the stomach as a high-stakes acid refinery, where the mucosal shield is under constant attack. Our job is to master the logic of this battlefield for your international boards. Let's move.
First up, GERD. Now for your exams, you've got to think way beyond just heartburn. See GERD as the critical first step toward Barrett's metaplasia. That's that dangerous cellular switch from the normal, tough squamous cells to these delicate columnar cells in the esophagus. So why is that so bad? Well, it's kind of like ripping out the fireproof tiles in a kitchen and putting up flammable wallpaper instead. You're just setting the stage for a much, much bigger fire, and in this case, that fire is esophageal cancer.
Next, peptic ulcer disease, the literal battle for the stomach wall. The logic for your board exam is actually pretty simple. You've got duodenal ulcers, we call them the hungry ones. Why? Because food actually makes the pain better. It coats the ulcer, shields it from the acid. But then you have gastric ulcers, the fearful ones. For them, food is the trigger. Eating stimulates more acid, which hits that ulcer directly and bam, pain. This is a classic board question, so you've got to lock this one in.
But here's the real secret weapon, the thing they love to test you on. H. pylori testing is what we call a washout game. And here's the bottom line. If your patient is taking proton pump inhibitors, PPIs, or antibiotics, any test you run for H. pylori is basically garbage. It's going to lie to you. You'll get it wrong. You have to master this or the whole refinery is going to blow.
Okay, before we dive deeper, we have to pause at the safety gate. This is our mandatory international medical disclaimer. All this content is designed for educational purposes, specifically for international medical exams. This is not medical advice. For any real-world clinical decisions, you always consult official guidelines and a specialist.
All right, let's run a quick simulation. So, you've got a patient, they were treated for H. pylori about 3 weeks ago, but they're still taking a PPI to help with their symptoms. Now, a colleague suggests doing a urea breath test today to make sure the bacteria is gone. So, what do? Is this the right move? Is it the right time?
No, absolutely not. This is a massive board trap. You simply cannot test for H. pylori while the patient is on the very meds that suppress it. The boards have these strict washout laws, and you have to know them cold. The patient must be off PPIs for at least 2 weeks, and they have to be off antibiotics or bismuth for a full 4 weeks. If you ignore these rules, you are guaranteed to get a false negative, and that means the patient keeps suffering from an infection you think you've cured. It's so critical for the patient's safety and for your exam score.
And if you test too early, you're walking right into a false negative. What does that mean? It means the bacteria are still there. They're kind of sleeping, suppressed by the medication. So you'll tell the patient they're cured when really the infection is just waiting to wake up and cause more trouble. Rule number 1, you have to respect the washout period.
Okay, let's pivot and uncover 2 other high-yield board traps they love to use. First, Barrett's esophagus. The key things to remember here are that salmon-colored tissue you see on an endoscopy and then grading for dysplasia. And dysplasia, that's just a fancy word for when the cells start to look weird and abnormal under a microscope. It's a huge precancer warning sign. The second trap is gastroparesis, and for that one, it's all about confirming that the stomach is emptying way too slowly.
So let's crack the Barrett's code. If your patient has Barrett's, but, and this is key, the biopsy shows no dysplasia, you do not scope them every year. That's total overkill, and it's the wrong answer on an exam. The current guidelines say you only need to do surveillance every 3 to 5 years. You got to burn that interval into your brain.
But what if that biopsy comes back and it says high-grade dysplasia? Whoa. Okay, that changes everything. This is a 5-alarm fire. You don't wait. You don't rescope in a few months. The very next step is to act immediately. You perform an endoscopic mucosal resection to get that precancerous tissue out of there.
And that leads us right into our second trap, gastroparesis. This is super common in patients with long-standing diabetes, right? All that high blood sugar just damages the nerves that control the stomach muscles. So if the boards ask for the next best step for a patient with nausea whose endoscopy was normal, the answer is a 4-hour gastric emptying study. And what's the magic number for diagnosis? If more than 10% of that meal is still just sitting in the stomach after 4 hours, boom, you've confirmed it. The stomach's engine has stalled.
All right, it is time to lock in this refinery logic. We are going to run a rapid-fire drill to burn these concepts right into your neural network. Welcome to the gastric matrix. You ready? Question 1. Epigastric pain that is relieved by eating. What is it?
Duodenal ulcer. That's the hungry one, where food is a friend. Locked.
Next up, pain is triggered by food, and the patient is losing weight. What's the diagnosis?
Gastric ulcer. And what's the mandatory next step? Biopsy. Every single time. Locked. What are the correct tests to confirm that H. pylori has been eradicated?
That's going to be a urea breath test or a stool antigen test. And just as important, what is it not? It is not serology because those antibodies can stay positive for years. Locked.
Okay, let's run through this final lockdown matrix to seal the deal. Pain relieved by food, that's your duodenal ulcer. Pain triggered by food, gastric ulcer, and you better biopsy it. You see intestinal metaplasia, that's the key word for Barrett's esophagus. Gastrin level over 1,000, you're thinking Zollinger-Ellison syndrome. And what's the big scary side effect of metoclopramide? Tardive dyskinesia, those uncontrollable movements. Logic is sealed.
And just like that, the gastric refinery is mapped. The high-yield logic has been encoded. Mission G1.2 is officially secured. You've now mastered the core concepts you need to absolutely dominate these questions on your exam.
But what happens when that refinery wall completely fails and the pipes burst? Well, that's when this whole GI journey enters the red zone. If you can't prioritize resuscitation over endoscopy, or if you cannot identify the lethal pathways of a variceal storm, you are not ready. Your next mission, should you choose to accept it, is G1.3, Emergency GI Bleeding and Variceal Storms. Engage now.